later on in the slide, trying to fix it. But I wanted to talk about a topic that has been coming up in a lot of our safety discussions, and that is, how do we check for a lesion or a stroke in the cerebellum? And there is a reason for that. People who have a cerebellar stroke are at really high risk for acutely decompensating. And we want to be able to recognize it as quickly as possible so we can take care of them in the most efficient and safe way. So,
she's working on it.
she's working on it. Okay.
Just start
So there are some pictures that I want to show you, but
and they're going to
the
be out in
cerebellum.
just a second.
The cerebellum is a part of the brain that is sort of sits in the back. It's called the posterior fossa. It's a smaller compartment. The cerebellum is about 10% of the volume of the brain. But by calculating, because it has very small neurons, it has more neurons than the rest of the brain combined. So it's a pretty, pretty important organ that way. Most of the time, and if you look at the research, it started around 1800, early 1800s, by people like Lucchini and then Babinski. A lot of people know about Babinski's sign and Holmes. Some of those people actually worked on animals and worked on people who had focal lesions. And they found that the biggest thing that we as clinicians, we as people, the biggest symptoms you see is motor control. And so often we think about ataxia as the sort of pathognomonic thing for cerebellum problems. And so that is one thing, but not everybody who has a cerebellar lesion comes with ataxia. There are so many other symptoms and syndromes that can come with that.
Okay.
And let's see, so one of the things I wanted to put is, I was talking about safety, but I think the important thing is whenever we touch a patient that comes to us from a different system, from the ER or from the ICU, one of the things that often happens is there are a set of people who have taken care of that patient. They've made some assumptions on diagnosis. And as a new person coming in, we need to be able to question those assumptions. And that is really important in any stroke patient, and particularly in patients with posterior stroke, because often people who have a stroke are at risk for having recurrent stroke. So you may have a patient who had a cortical stroke and now has another stroke, which may be in the cerebellum, or it may be that the patient came with cardiac issue and now has a stroke because heart and brain are linked. So it's really important that when we inherit a patient that we question it and we do a good exam. And we examine not just the cortical function, the thinking, the alertness, the orientation, how they speak, but also some of these components that are often missed, and we call them cerebellar parts. So we had a case recently, and I went through a lot of discussion. I'm not going to talk too much about it, but a young guy who had a history of alcohol use, who was acutely altered at home. He tried to wait out to see if his symptoms got better, but it didn't. His daughter, who is a chiropractor, noticed that the patient was ataxic, his speech was different, he was just not able to balance himself. So the EMS was called, and they called in to the ER saying that we're bringing in a stroke. When the patient came in here, he was just really encephalopathic. The exam initial felt maybe he's generally weak, he just doesn't follow commands easily. And so they felt that this is not a stroke, the cast is a stroke cord. They did a CT head, and the CT head didn't pick up anything, which usually it doesn't. He did have elevated troponin, his blood pressure was really high, so they put him on the cardiac pathway. And then next morning, overnight he was tremulous, so they thought it must be from alcohol withdrawal. They gave him lorazepam, and next morning he was obtunded, he developed unequal pupils, and then his CT right here on the left that you see this is the cerebellum in the back, and you can see this area is hypodense on the CT, and there's this small hyperdensity in the middle, which is a small bleed. So the person had a cerebellar stroke that was evolving, which is often missed in the initial CT scan. And then a few days later, he got an MRI. He had a stroke in the brainstem. Here, bleeding. He needed a surgery in the back. He needed an EVD on the front, and he got permanently disabled. And some of those things can be avoided if we detect it early. We can take them for surgery early. We can put a drain in early so the pressure doesn't build up. So it's really important for us when we take in a patient to do a test and make sure that we're not missing some of these less known areas. This is not the only case. We've had 4 or 5 cases now in just the last 2 months where people have come with cerebellar stroke and they're just really, really hard to tease apart. And one of the issues also is that some of the testing that is done for cerebellar lesions is not often done routinely. So it does represent a decent proportion of ischemic strokes, about 30% of strokes are that way. It's associated with high risk of early recurrence, so people who had any stroke in the posterior circulation are at high risk for and requires accurate localization. This is a high-level picture. So this is the cerebellum. It's a view from the side. This is the cerebellum. This is the brainstem. So you can see the medulla, the pons, and then the big brain is over there. And the main vascular supply for the back of the brain is through these vertebral arteries, which are coming in right here. They kind of turn around, go in, and then 2 of them merge together to become a basilar artery, which supplies a lot of the backside of the brain and as well as the cerebellum. The 3 big vessels that are supplying the cerebellum is this something called pica, posterior inferior cerebellar artery, ICA right there, and then the superior cerebellar artery. They kind of supply the whole thing. But the key thing is, if someone has a stroke here, which may have been from an emboli from the birth, you can see that it can affect any of these areas. It can affect the brainstem, it can affect something else. So if you see other symptoms along with the cerebellar symptoms, then it's really helpful in localization. This is the posterior circulation. But if you had only one symptom, for example, if someone comes with vertigo, that can be from many different areas. It could be from the ear, it could be from the brainstem, it could be from the cerebellum. So those are hard to localize. It's just like if you want to draw a line, you need 2 points, it helps. Similarly, if you have multiple symptoms, it helps. And to get multiple symptoms, we need to do an exam. We need to do a good exam. And that's going to be the focus of this presentation. I'm not going to go through all the vessels. I kind of went through it, because the main ones are the ones we talked about. We talked a little bit about, there's one interesting thing about cerebellar function. We talked about motor. So in terms of motor control, the cerebellum is about precision, about coordination, about making the movement smooth. So that is kind of where it is. But some people think that that same function that happens for motor also happens for emotion. So people who have had cerebellar problems will have emotional overshoot or undershoot, those kinds of or coordination problems. And that's a really interesting area of study that people are still studying. In terms of clinical presentation, because cerebellum usually does not live in isolation, it lives with other things, so you can often have associated symptoms. So if you start seeing symptoms like vertigo, ataxia, and if you see visual field deficit, it's not a function of cerebellum, but it's a function of this part of the brain, the occipital area, which is supplied by the same. So if you see visual field deficit, you could potentially consider that this could also be a cerebellum. So that would be important to know. Eye movement disorders are very common with cerebellum, and so looking for nystagmus, looking for whether they can move their eyes smoothly. Again, motor movement, everything has to be smooth if the cerebellum is functioning fine. Weakness can present if there is a brainstem problem. Usually weakness is not a symptom of cerebellum itself, but it can be an associated symptom. Consciousness is not necessarily part of cerebellum, but in the brainstem as well as in the thalamus, both of them can be supplying by the posterior circulation. And then you can have lots of other symptoms which are associated with brainstem, like breathing problems, like blood pressure, autonomic dysfunction. When they looked at just the frequency of symptoms, you can see that the dizziness and vertigo is on the top. Speech changes, dysarthria is common. Ataxia and nystagmus, these are the common symptoms. And we'll talk about how to diagnose them or how to evaluate for them. Some of these are just things that people will describe, and a lot of things we can test ourselves. So when we do a cerebellar exam, we look for abnormalities in eye movements. So starting from the top, eye movements. We look for speech changes. We look for limb posture, limb coordination, and then we look for kind of balance and gait. How do we do that? So those are the categories in which we think about cerebellar exam. There are some subtle findings that are hard to often see in an exam, like hypotonia. The tone is regulated by cerebellum, so you may have patients not having the proper, like asymmetric tone. One side is firmer or stiffer than the other. So let's see if we can make this video work. And I want to go somewhere in the middle of the video. Let's see if I can control it.
The principal sign.
All right, so this is a different video, but this is one of the tests that we very commonly do. Everybody here has probably done this test. This is the finger to nose test. But the issue is when we do this test, it's hard to know what part is cerebellum. Could it be an essential tremor? Could it be just that the patient is not focusing? What if the finger is here and the patient is consistently going here? Is that a dysmetria? So there are a lot of issues with this test, in interpreting this test. We know that we are asking the patient to touch their nose and then touch the finger. However, when it's abnormal, what constitutes a cerebellar problem is the issue. So in this test, in this video, you will see initially this person who has a cerebellar lesion trying to do it in fast motion, and then there will be slow motion. And one of the things you should see is that how does this person correct their mistakes, and whether they're going straight for the target or not. So as you know, cerebellum is helping smooth and coordinate movement. And the reason we do this finger to nose test is because it requires immense amount of coordination. There are so for this joint, there's one joint here, there's one here, there's one here, there's one here, there's one here. So all these joints have to work in tandem for a movement smoothly going to the finger and then back to the nose, right? And that requires, a lot of coordination from cerebellum. So people with cerebellar lesions, when they reach the end, they may actually overshoot or undershoot, and then they will correct. Same way when they reach the nose, they may overshoot, undershoot, and then they will correct. So notice that in this video. Let's start that.
In this example, the patient is asked to repeatedly touch the examiner's finger and then her own nose. Note that the initial trajectory is misdirected and that the ensuing mid-course correction overcorrects and the finger misses the target.
Great. So that would be good.
Observed.
So what if someone has, a tremor like this, just always like this? Could that be cerebellum? That is usually not the case, so that people with essential tremor can have a lot of tremor. People with Parkinson's can have tremor like that. It's just there. But the cerebellar tremor is kind of more towards the end, and they're basically not able to straight go towards the point. They're going away from it. They're going out, in, out, in. So that's always the characteristic thing about motor control part of cerebellum. Any questions for this part? It's a really commonly done finger to move. All right.
Dr.
So,
Singh, I think this one does not have a link, so I didn't find it.
Right. This is a really cool video. But we can try talking about it, and maybe we can have a volunteer. I can check. Is anybody willing to volunteer? You can. That would be good. Thank you. So if you have a seat here, what you do is, what you're looking again for is that when I'll ask her, you focus on her eyes, and just stand right in front of the patient and don't stand so close that they feel that you're blurry and they can't focus. So stand about an arm arm length away. And then from there, you show a finger and you say, follow my finger with your eyes without turning the head. Oh, there it is.
I found it.
So we'll show it. Let's do this normal one. So then you ask them to look towards one side, and you're looking at their eyes while they're looking at the finger. You're not looking at the finger, they are. And then keeping it about arm length away, then you have them look to the other side. And usually for cerebellar lesions, you will be able to see problems in this. In her case, it's completely smooth pursuit. And then you can ask them to look up, and you look down. So that would be kind of how you do it normally in a patient. And in this patient, what you will see is when you ask the person to fix on a target, it's very hard for a person with cerebellar lesion to do that. Their eyes will just wander around, and that would tell you that there's something wrong. Also, when they try to focus and move with your finger, they will always try to overshoot. So instead of the eyes going smoothly this way, they'll actually go further back, and then they will correct it. And sometimes both eyes may not go together. In addition, their eyeballs may be moving around like this. So you can see some sort of torsional nystagmus. And then you try it the other way, then you can see that problem. So just focus on this patient. It's a really interesting example. You can see already she has a little bit of discounted gaze. So she's trying to fix it.
Look at that spot?
Yes.
Okay. I'm going to try to get you focused again. Good. Now just look to the right. Just turn your eyes over there. Yeah, now look to the left.
So the other thing notice is her nystagmus changes direction. So the direction of a nystagmus is decided by the fast pace. So anything like this, it will go fast this way and come slow this way. So the direction is right beating. And then when she looks towards the left, it becomes left beating. And when the direction of the nystagmus changes, that is almost always concerning for a posterior circulation problem. For patients who have ear problem, their direction would not change. They would go fast beating. If this ear is the problem, they would go fast beating here. And they will go here, but they will beat slow, but it will still be in the same direction. And in the patient with cerebellar lesion, you can see that the direction will actually change. Let's see more. Let's keep looking at the video.
Thank you so much. Now look ahead. Straight ahead. Lovely. Now turn your head like you're saying no, but still look at that spot that you're looking at.
What side?
This spot here, I just want you to turn your head like you're saying no. There you go. Now come the other way. Oh, look at the camera. Look, there you go. Now one more time for me. Look at me. Okay, now the other way. Oh, fabulous. You're great.
Thank you.
So very, very, obvious example. Most of our patients are not this obvious. All right, so you're looking at very subtle sign. You should take your time. It's, usually people who have had stroke, the nystagmus is not going to go away. So you can take your time. You can have them look this way. You can have them look this way. You can have them look up. And often you can't see the pupil, so you see the sclera. You see the blood vessels in the white of the eye, and those are sometimes more obvious to see than actual pupil, and then you can see kind of rotatory nystagmus component. And the speech is pretty interesting for cerebellar people, right? So they classically say they have scanning speech, which means they kind of extend the sounds. And classically people say, can you say baby hippopotamus, because hippopotamus has so many sub-sounds, and so they will try to compartmentalize the sound to speak. They just can't do it all in its sequence. And some people say British constitution. And I can't mimic it completely, but I think it's like British, they'll just extend the sounds, and constitution, those kinds of sounds. So like we often see dysarthria, like slurred speech, like where it's just, they're just having difficulty with this. But ataxic people is different than slurred speech, and you just have to kind of get used to that sound where they're just scanning. And obviously if you see other symptoms, then you see to say what's going on. The other thing I want to see is, maybe I can come down here back. So the other thing is, they just, it's hard for them to go back to the position they were in. Let's have you extend your arms like this and have you close your eyes. So see what happens when I do this. She comes back exactly where she was, right? She comes back exactly right there. So you can push like that and it's just come back exactly like that. For a person with ataxia or a cerebellar lesion, you push like this and they'll go like this. It's really hard for them to stay in the same spot. And same way you can try on the other side. And if you see an asymmetry, that would be concerning for the same problem. And then another thing is rebound. So make your arms like this, a little bit out that, right here. And then you kind of protect their face with the other hand. And then you ask them to pull towards themselves. So then she's pulling and then you let it go. And if you let it go, she's able to just keep it right there. But a person with ataxia will not be able to. They may actually just go further and hit their head. So that's another example of where it's just very hard for them to coordinate. The other test that we can do is to check for reflexes. And it's hard to do right there and have you all see it. But you know, often when you do a reflex, the leg will pop forward and then come back, and it'll probably swing once. In patients who are really hyperreflexive, it may swing twice. But for people who have had cerebellar lesion, and I have a video, I imagine there's another video.
Yes.
They just can't stop, it just keeps going up and down like this. So it's called peduncular knee reflex. So this is the difference. So this is not this video, but right, that's one, yes.
This one?
No, the other one. Is that the one? Yes, that one.
This one?
Right. So go in the middle of that.
Lesion. No,
Okay,
the pendulum like
so this guy has a left cerebellar lesion. Okay, so just keep going. No, then you're perfect. Just go back right there and just start. Thank you.
of the left leg while eliciting this knee jerk.
So they just can't stop that. So there's so many different ways in which we can test for an injury in the cerebellum, not just finger to nose, not just heel to shin. Let's go back to another video. Another test that we have is, it's a long name, I think you can ask the cerebellar patients about it. It's called dysdodoco. Right, that one. Or for short, we can say DDK. Right? So this is where we ask the patient to take, to put one palm flat and take the other palm and then do like this, right? And if they can do like this, it requires a lot of coordination, they're doing it, and then same way on the other side. So now watch this patient, let's go in the middle. A little bit further ahead, a little bit more, right there, just a little bit behind. Just a little, right, yeah. So that's an extreme example, right? A lot of other people can have problems too. Frontal lobe lesions, they can't plan these kinds of activities, so they may have problems. But look at how it attacks it. And that's the last part that I think you can stop that one. So we are almost out of time. So I want to talk about the most important thing that we can do, and the easiest thing we can do is to make the patient stand and walk. For cerebral, right? That is the test that requires the most amount of coordination for a patient. So if you make a cerebellar lesion stroke patient stand, they will usually stand with broad base. They just can't stand with feet together. And if you make them stand, they're like swaying like this, and they just can't maintain the posture. Posture requires the two muscles to counteract each other. Like opposing muscles are always helping you balance. And those people just, the overshoot or undershoot. And when they're walking, or actually when they're sitting, they will start listing towards the side where the lesion is. So they just can't even balance sitting. And if they're trying to walk, they will obviously have a wide base thing, and they would be kind of like really leaning towards the side where the stroke is, and then it'll be like falling that way. And it's just very hard to balance. And that is an example. Let's go in the middle of that. Middle of that video, sorry. After she gets rid of that walker. Keep going, keep going, keep going. Right there, yes. So that's an ataxic gait. You can't miss it. So if you made a patient walk, you just can't miss it. They just cannot balance them. They can't stand. First of all, they won't stand in one place. So if we had made some of these patients who came in the ER with posterior circulation symptoms, we made them stand and walk, and we saw this, we would know where the problem is, right? We would not miss these things. So what we can do is when the patients come to the floor, if you see that there's something funny about their hand movement, let's have them stand up, and let's have them walk, because that has so many different things. And then there are some other tests that you can have. You can work with the providers, or you can work with people, the physical therapies, occupational therapists who do these tests a lot, to see whether there is any component of circulation. And if there is any positive ataxia or any of these symptoms, then it's a emergency. It's someone who needs to be in ICU, getting Q1-hour neuro checks, because the part of the brain where the stroke is can swell and come to a point where there's no more space to expand. It will start hitting on the brainstem and start causing a stroke in the brainstem. And the brainstem strokes are very disabling. And once you have a stroke in that area, then you cannot recover most of the function. And then the worst case is these patients just go to sleep and they just die. And you may have a really normal exam at one moment, and 4 hours later, if they're on the floor, they are dead. So it can be pretty bad. So it's really important for us to do these tests and find these patients in the first hours. Any questions?
I just have a question. If you have somebody with a scissoring gait, is
Like that?
What does that indicate? Yeah.
Like that. I'm not sure. Do you?
Me? I don't know if that was this or.
I know. So the cerebellar gait is more wide-based, right? So if someone can walk like that, that is that's a normal gait. That's a normal gait, right? If someone is doing like that, I am not sure. But like there's a spastic gait, which is where they just can't flex this leg. It's a spastic. So those people will drag their feet like that, right? So there are all these people. I'm not sure if that requires a lot of coordination. So
usually scissoring is on one side, though, and it's related to weakness or over-shifting over to one side. So they're over-shifting and the other foot's just coming right where it needs to land. You'll generally see it just be one leg that's scissoring.
One side, so more like just motor cortex.
It's motor coordination, weakness on one side, how much weight shift they're doing. I don't think I've ever seen it where they're really doing both sides.
Or clever, what's the one where you send to rehab sometimes?
Like the
Conversion.
So there is antalgic gait where they are doing a lot.
Well, yeah.
Like they're really doing a lot of coordination, and they're using a lot of strength from hip flexions, from knee flexing, So they're using so many muscles, and they're pretty coordinated because they don't fall.
Yeah,
so
and that's
those
more
are-
like compensation for weakness or pain or something.
Right. Anything else?
Thank you. That was very neat.
That was very good.